Is it true that Alzheimer's is the third leading cause of death? Are there any drugs or medical procedures that reverse it?
It is true, and this is something that Professor Christine Yaffe showed several years ago, and her team showed that if you look at serial autopsies, it is actually the third leading. It's often said to be the sixth leading cause of death. One way or another, it's very common. But here, to put it in perspective, we talk often about the pandemic, and of course, SARS-CoV-2 and COVID-19 has killed over 400,000 Americans. We're heading for 500,000. This is a huge number of people. But for perspective, Alzheimer's will kill about 100 times, about 45 million Americans of the currently living Americans. So as large as the pandemic is, and as much as it's affecting our country, Alzheimer's is actually a substantially larger pandemic. And as far as drugs, I think, again, it's important to put that in perspective. Just recently, a number of the antibodies were evaluated and big statements made. This looks really good. So first of all, let's point out, they didn't make anybody better. They didn't stop the disease from progressing. The big thing that was trumpeted was they slowed the disease progression by about 1/3. So as you can see, we need to do much better. For people to be just continuing downhill, but a little bit slower, doesn't help us a lot. We need to be able to take people who are going downhill and now actually make them better. So the answer is there's no drug today that has the impact that is a sustainable improvement in symptoms.
What made you write the book, The End of Alzheimer's, the first program to prevent and reverse cognitive decline?
Yeah, it was that we had spent 30 years in the laboratory looking at what actually is Alzheimer's disease. In other words, we wanted to understand the fundamental nature of the problem, what's driving the degenerative process, in enough detail that we could begin to fashion the first effective treatments. Because in fact, the area of neurodegenerative diseases has been the area of greatest biomedical therapeutic failure. As they say, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. And you can say the same thing about Lou Gehrig's disease, and about Huntington's disease, and about Lewy body disease, and frontotemporal dementia. So this is a huge, huge problem. And so after 30 years, we finally understood that, in fact, Alzheimer's is much different than we had been led to believe. It's a different sort of thing. You have to treat it differently. You have to think about it differently. It really is a protective response to a set of insults, dozens and dozens of these insults. So instead of treating by giving a plan ahead of time and saying, okay, we're going to treat it with this no matter what, you have to do just the opposite. You've got to flip the script and say, for each person, we're going to look at all the different potential contributors, and then we're going to target those with a personalized precision medicine protocol. And that is the 21st century medicine. That's the way of the future. And unfortunately, at Alzheimer's centers around the world, they're practicing this old-fashioned kind of medicine where you decide before the person comes in, well, whatever they have, if it's Alzheimer's, we're going to give them this drug that doesn't work, which actually is a kind of barbaric approach. So I wanted to show people that, in fact, the research shows something completely different than what is currently being done, and to talk about the first people who actually got better and stayed better. We have people over 9 years now who have improved, that would have been in nursing homes, that have improved, that are still working and doing very well. So actually I have another book coming out this August that's called The First Survivors of Alzheimer's Disease. And this is 7 stories from people who actually were told that you've got Alzheimer's, you're going to die, and they're now back doing very, very well. And it's their personal stories.
Is there more than one type of Alzheimer's?
Yes. So again, we assume this is Alzheimer's. So we say, yeah, Alzheimer's, and we don't know what causes it, and we don't have anything to treat it. But if you start delving into what is actually driving this process, which is what we want to know, we want to know, why does each person have this degenerative process? It turns out there are dozens and dozens of things, as I mentioned earlier. And we usually tell the patients, imagine you have a roof with 36 holes. Well, a drug is an excellent patch for one hole, but it doesn't do a lot for the other 35. So you want it for each person, you want to measure those. Now, when we do that, what we find is that there are groups. So people who have a mostly inflammatory push toward and drive toward degenerative diseases. And you can actually trace the molecular pathways from NF-kappa B, which is activated with inflammation, to where the APP, the amyloid precursor protein that is critical for Alzheimer's, is cleaved. And you can trace the pathway to show that when you have ongoing chronic inflammation, you drive this process that leads to the amyloid of what we call Alzheimer's disease. And by the way, that amyloid, as was shown by Professor Rudy Tanzi and Robert Moyer from Harvard, is actually a protected. It is an antimicrobial peptide. So again, it's a response to an insult. So there are people that have mostly inflammatory related insults, all sorts of different pathogens, Lyme disease and P. gingivalis from your mouth and herpes simplex from your lip and molds from your sinuses and things like that. Then we call that type 1 or inflammatory or hot Alzheimer's. Then there's type 2, which is atrophic. These are people that just don't have the support, hormonal support, nutritional support, and growth factor support or trophic factor support. Those things you need to keep this massive neural network going. You have over 500 trillion synapses in your brain. To keep those going, you've got to have support. If you withdraw that, you downsize. And that's type 2 Alzheimer's or cold or atrophic. Now, interestingly, there's a third type, which we call type 1.5, glycotoxic. And that's because it has features of both. It has features of inflammation from the non-enzymatic glycation that occurs on hundreds and hundreds of proteins. Of course, we measure this as hemoglobin A1C. That's glycation of hemoglobin, but there is glycation of all sorts of things. It changes the shape, it changes the function of these proteins, and so it gives you this inflammatory response, but it also gives you an atrophic response because you become insulin resistant. So now you can actually measure this. Beautiful work by Professor Ed Getzel out of UCSF, showing that you can actually see that there is insulin resistance in the neural exosomes deriving from the brain of virtually everybody with Alzheimer's disease. So that's type 1.5 or glycotoxic. Then type 3 is toxic, and the toxins tend to come in 3 different types. They're inorganics, things like mercury, and the more and more evidence now on air pollution as a critical feature that increases risk for Alzheimer's. Second one is organic toxins, formaldehyde, toluene, benzene, glyphosate, these sorts of things. And then the third group is the biotoxins, things that come surprisingly from things like molds. And there are special molds that actually cause these things like Stachybotrys and penicillium and aspergillus, chaetomium, wallemia. These are common ones that give you these toxins. So it's not all molds, but special ones that can give you this problem. That's type 3 or toxic. Type 4 is vascular. So it's the energetics really that are being driven by your vascular support. You need the oxygen, you need the cerebral blood flow, you need the ketones, you need the mitochondrial function. And then type 5 is traumatic. So although people do have mixtures of these, many times we see people who have some glycotoxic and some inflammatory, for example. But the bottom line here is, yes, there are different subtypes of Alzheimer's, and that helps you to understand so that you know how to get best outcomes for these people.
Does alcohol consumption contribute to dementia?
Yes, that's a good point. And of course, alcohol consumption has been associated with dementia for years. And the one that we hear about is Korsakoff's dementia, of course, where you lose the ability to consolidate new memory. And this is related to a B1 deficiency. But alcohol does increase risk modestly. And so it is a factor in Alzheimer's, but it's not one of the more common ones.
Why do you believe Alzheimer's will be considered an antiquated disease in the near future?
Yeah, so, it's interesting. We've all been through scourges, and of course, history has recorded all these scourges. There was a time when people were all concerned about leprosy. There was a time when people were all concerned about tuberculosis. When I was a little boy, my mother would talk about polio. Everybody was concerned because, the guy down the street would wake up one morning and have polio. And so we've gone through these scourges. Of course, HIV was a big one for the 80s and especially in early 90s, just a huge, huge problem. And for each of these, we've ultimately understood them. We've ultimately done something about them, and they have become past scourges. So we have a past scourge of leprosy and a past scourge. Now, HIV still exists, but we're much, much better at treating it. Again, thanks in part to all the tremendous healthcare workers. And I'll mention, of course, David Ho, who did such a fantastic job with triple therapy. And so it is now a disease that is still a horrible disease, but it's a manageable disease. We're doing better and better with multiple cancers. And things are continuing, of course. With the immune support, people are doing very, very well. So what I've pointed out is that Alzheimer's will become one of these former scourges. And in fact, we're already on the way. We have people who've improved and who've stayed improved for, as I mentioned, over 9 years and counting. And the idea is if you actually get at what's driving this process, then when you improve these people, they don't get this again. Now, if they go off, if they actually do the wrong things, yes, they can go back to this. And I think, right now we are in a global scourge of non-communicable disease, the pandemic notwithstanding, and we may have more pandemics, and of course, people are dealing with that. But the big problem at the moment, what is killing most of us, is the non-communicable diseases, the cardiovascular disease, the cancer, the neurodegenerative disease, the renal failure, things like that. And I think that this is the century in which these will become past scourges.
Please discuss the dual role of amyloid as a toxin and as a protectant.
Yeah, I'm so glad you asked that question, because it really is one of the cruxes of understanding this illness and what to do about it. And, it doesn't make sense. People have said, well, wait a minute, is amyloid good? Is amyloid bad? Well, if you understand that it's neither, it's both. So here's the thing. What happened, let's take the analogy of COVID-19. So, a little over a year ago, the whole world was attacked by this virus, SARS-CoV-2. We were told to shelter in place, to distance, to be careful. And so what happened? Businesses were shut down. We went into a recession. Things pulled back. So we were protecting ourselves from this insult, the virus, by distancing, by shutting down a lot of what was going on. People stopped going to conferences and things like that. So in protecting ourselves, we were shutting down our interactions. And this is very much like what's happened. And there are a lot, actually, of parallels between COVID-19 and Alzheimer's disease. Now, in Alzheimer's disease, what happens is you have a molecule called APP, amyloid precursor protein, which is actually, interestingly, a master switch. And so what happens is when your body and your brain senses that things are positive, you have enough trophic support, you have enough nutrition, you have enough hormonal support, you don't have a lot of inflammation, you don't have a lot of infection, things are good, then just like the president of your country or the head of your company says things are good, we're going to grow, we're going to build. You're able to have that neuroplasticity, you can learn new things, you can make new and store new synapses. Your APP gets cleaved at a single site, which is the alpha site, and you get two resultant peptides, which are SAPP alpha and alpha CTF, C-terminal fragment. These things, well, one's inside the cell, one's outside the cell. Things are good. You now grow, you make new neurite, you make new connections, and you support that. And you make new memories, that's great. And this is what's happening, for most of your life. You've got a balance of this with the other side of things. This same APP, when you now have inflammation, reduced hormonal support, reduced nutritional support, on and on, the same thing is actually cut at 3 sites, beta, gamma, and caspase. You now have 4 fragments, 2 for outside and 2 for inside, that are now telling you things are not good. We must go from growth mode to protection mode. It's not trying to kill you, it's protection mode. And one of the 4 peptides it's made is the amyloid beta peptide. So you can see everyone's been focused on amyloid. It's more than that, it's a bigger picture. But the amyloid, as shown by Rudy Tanzi and Robert Moyer, has an antimicrobial effect. So this is actually a protective mode for your APP cleavage. It is killing, and they've shown it kills some viruses, it kills some bacteria, some fungi. So this is an antimicrobial, this is protective mode. Now, the protection, unfortunately, is just like what we saw with COVID-19. The protection includes downsizing. So the brain is strategizing to say, I must throw myself into protection mode. I will survive by living with fewer synapses. And of course, the problem is if you don't figure out what's causing this, which doesn't happen when you go to a center of excellence, they're not looking at what's actually causing this. And so you just keep downsizing, downsizing, downsizing. Pretty soon you can't dress yourself, you can't speak, and you die of Alzheimer's disease. So the whole goal here is to recognize that yes, you are in protection mode. And typically what's been shown is this is ongoing for about 20 years before a diagnosis of Alzheimer's. So when we think of Alzheimer's disease with loss of activities of daily living, that's something that is like saying end-stage cancer. We have over a decade to get at this ahead of time when there are minimal symptoms, which is why we encourage people, please, if you don't get on prevention, then at least get in at the earliest possible symptoms. Don't say, well, maybe it's not a problem. No, let's find out what's going on and you can do something about it. So you're right. Amyloid is a downsizer. It is reducing your synaptic number. It's putting a stress on your neural networks, but it's also protecting them. And to some extent, it's saying survival of the fittest. We know we're going to have to downsize. So what we're going to do is we're going to put a stress on the system, and the ones that are going to do poorly are going to die off. It's a little bit like saying, imagine you say, we've got 100 people here, we can only feed 80. So we can either give a little bit to each person and watch people die off, or we can put everyone under stress. The 20 are going to die quickly and everyone else is going to be fine. And so that's to some extent what's happening with this amyloid. You are downsizing the system in order to survive. So our job, as I said, find out what's downsizing it, address those things, and then support it as you're now able to make new synapses once again.
Does water fasting or green juice fasting help with preventing Alzheimer's? Should we do a weekly, monthly, or even yearly fast?
It's a great point. So fasting, in fact, is very helpful. And the approach that we take, which is called KetoFlex 12-3, a specific nutritional approach as part of it, again, an overall program that is changing your neurochemistry to allow you to keep and make synapses. Does include some fasting, and you have to be careful, as you know, if you are underweight, be careful. You can actually hurt yourself with fasting. But for most of us, who are able to fast and aren't terribly thin and low BMIs down 18, 17, then fasting can be helpful. Of course, it does a number of things. It improves inflammation. It improves blood pressure. It enhances autophagy. All of these things helpful for cognitive decline. And it improves ketosis. And ketosis is critical because what's happening when you have Alzheimer's or pre-Alzheimer's, you have an energetic emergency. You are not supplying the energy to your brain that is required for optimal neuroplasticity. And you can measure that on a PET scan. You look at the PET scan, you see decreased glucose utilization in the temporal and parietal regions of the brain. And you can bridge that gap, as Dr. Stephen Kinane has shown, with increasing ketone level. And so you can do this, you can start out doing this exogenously because we want to bridge that gap as soon as possible. But in the long run, it's preferable to do it endogenously. And part of that is fasting. So yes, absolutely fasting can be very helpful. And how often to do it? We typically have people doing it overnight for 12 to 16 hours, but some people like to do it once a week for a whole day, or even once a month for a couple of days. And of course, there's fasting mimicking diet that Professor Walter Longo has, and there are other ways to do this as well. But yes, the phenomenon of fasting and the positive impact it has for cognition, no question.
What do you believe causes Alzheimer's? What are the negative effects of plaque buildup in the brain?
Yeah, it's a great point. And the research that we did over 30 years suggests a very different look at Alzheimer's. It suggests that Alzheimer's, what we call Alzheimer's, which is really just a pathology, Alzheimer's is actually an insufficiency. That is to say, there's a set of things that are required for driving synapse formation and synapse maintenance, and we call that synaptoblastic signaling. And it's trophic factors, and it's nutritional factors, and it's hormones, and all these sorts of things. And on the other hand, and of course it's energetics, ketones, and things like that, there is a whole set of things that are synaptoclastic, that are pulling back. And those are things like anything that's causing chronic inflammation, and then things like toxins, the various toxins that we talked about earlier. And so your probability of developing Alzheimer's is proportional to an integral. So over time, summing up of the various negative, the synaptoclastic signals that we just talked about, divided by the synaptoblastic signals that we talked about. And by the way, this is no different than what happens with osteoporosis. There we have osteoclastic signals predominating over osteoblastic signals. This is no different than, if you have two groups, let's say you've got some contractors that work at your house. Let's say you got one set that does the demolition, one set that does the building. And let's say for 10 years, the guys that did the demolition always did extra, and the guys that did the construction never showed up. Your house would just start getting smaller. And that's exactly what's happening with osteoporosis, and it's exactly what's happening with Alzheimer's disease. So we want to support the synaptoblastic signals, and we want to decrease the synaptoclastic signals. So the bottom line is, Alzheimer's is caused by a set of factors that alters the balance in synaptic signaling that literally is an insufficiency in the ability to support that network. So in order to protect yourself, in order to deal with lower support, you are downsizing that network. And as you're doing that, you're making this protective amyloid. So the pathologist looks in there and says, aha, you have Alzheimer's disease. And we don't know what causes it. Well, we know a lot of things that contribute to it. And so when you say Alzheimer's disease, you should never put a period after Alzheimer's disease. Alzheimer's disease due to what? It's like saying fever. Fever due to what? And of course, in the 1600s, you could die of fever. But today, we want to say, well, fever due to what? Was it COVID-19? Was it tuberculosis? Was it HIV? What was it that actually gave you that feature? Was it, that fever? Was it pneumococcal pneumonia? Same thing with Alzheimer's. We need to, and in Alzheimer's, it's usually several things. We typically find between 10 and 25 different contributors. You need to ferret them out. You need to address those things. So Alzheimer's disease due to what?
How do you know if you have cognitive decline and if it's getting worse?
Yeah, I'm so glad you asked that question because it is critical. This is one of the biggest problems. Alzheimer's is a stealthy reaper. It will sneak up on you because the problem is, we say, oh, I'm just getting a little older. And there's an old joke about this because people will often tell me, my spouse is not that good either. So we're probably just getting a little older. And there's a terrible old joke about, a guy who said to his wife, he said, I've noticed, your memory is not quite what it should be. And I'm going to give you a little test. I want you to go in the kitchen and I want you to make 2 scrambled eggs, hash browns, 2 pieces of toast with butter, and some black coffee. And I just want to give you, she says, hey, I can do that, no problem. I've got a great memory. She goes in and she hears the pans banging and all these things. 15 minutes later, she walks out. She's got a parfait glass that's got ice cream. It's got some chocolate sauce on top. It's got some whipped cream. And he looks and he says, hey, you forgot the cherry. So the point is that so commonly we'll have multiple people and they say, well, the other one's about the same. They all think that they're just getting a little older. In fact, we should not be having such symptoms. As you know, people get to 100 and often are very sharp. So if you're having problems, if you have changes, you're not remembering things as well, or you're having trouble at your job, or you're having trouble remembering your keys, this is a red flag. Now, people will say, oh, it's probably not Alzheimer's. Well, it may or may not be, but down the line, you could be heading for Alzheimer's. So this is why we recommend that everybody who's 45 years or older get a cognoscopy. Just as when you turn 50, everybody knows you should get a colonoscopy. Please get a cognoscopy when you turn 45 or older and make sure that everything's okay. And if you begin to have changes, you begin to see that you're not so sharp, don't let someone tell you, oh yeah, you know, you're 52 and you're just getting older, because you should actually be sharp until you're 100. And so let's make sure that you can do this. And in fact, it sneaks up on you because of that. And so frequently what will happen is doctors will say, you know, I think you're just getting a little older, but, come back in a year. And they keep saying, come back in a year, come back in a year. And then they finally say, oh, sorry, it's Alzheimer's. There's nothing we can do about it. Well, in fact, the earlier you start, the more there is to do about it, the easier it is. And we see people all the time who dramatically improve their scores with cognitive assessment. So please start early. Don't let it sneak up on you. And actually, Alzheimer's should be a rare disease. This should be uncommon because we can address these various insufficiencies. And therefore, if to do that, please get started early, because it's so much easier when you get started early. And I should just add one more thing, which is there are two general presentations for people who are on their way to Alzheimer's. About 2/3 of people, it's memory. As you know, that's the common thing. My memory's not what it used to be. And it's specifically recent memory. So they'll still remember their first grade teacher often, but they won't remember what they had for breakfast this morning or where their keys are, things like that. But about 1/3 of people present with a non-amnestic presentation. That is to say that it's not so much about the memory. And those people, it's other things. It's facial recognition, it's word finding, it's organization. That's a big one. So-called executive dysfunction. So people can't organize things and get everything together. They'll get a new iPhone and they just can't kind of put it all together. They can't organize things at their job. These are the ones that tend to lose their jobs the most quickly, because you can do pretty well with a not great memory for a long time because you've learned so many things earlier in your life. And, it's interesting that this is the way the brain downsizes. If I said to you, okay, you have a choice. You can wake up tomorrow morning and you can either forget how to do your job, how to speak, how to breathe, how to do one of these critical things, or you can forget the Friends rerun from tonight. That's an easy choice. And that's the choice your brain is making most of the time when things aren't good. Like, okay, I can do pretty well with what I already have. And that's why, by the way, people go for years and years and years and do fairly well. And unfortunately, they're hurting themselves if they don't get started early. That is the canary in the mine telling you something's wrong. So you may have these non-amnestic symptoms as well. Dyscalculia is another one. Problem with making a tip, paying bills, any sort of calculations. So please take heed of those things early on and get evaluated, and get on prevention or reverse. If you've got symptoms already, of course, it's reversal, and you can do very, very well.
Is dementia contagious? Can you catch it? Does it spread like COVID?
Yeah, that's a great point. In general, this is a non-communicable disease, and it doesn't spread. However, there are specific cases, things like Creutzfeldt-Jakob disease, mad cow disease that was a big concern about 25 years ago. And so there are cases, and we do know that this phenomenon, this amyloidosis, does have this amplifying effect. So it's very interesting. Your systems in your body have two kinds of feedback. And so we've all heard about homeostatic feedback, which is a negative type of feedback. So your serum pH 7.4, you don't ever want it to be 10.4, you don't ever want it to be 2.4. So if you drink a soda and it gets a little more, if you get a little more acid, which obviously you shouldn't be doing anyway because of the carbs, et cetera. But if you do that, then your system helps. It actually has metabolic and respiratory responses that bring you back. So this is negative feedback, homeostatic feedback. Interestingly, there's a second set of things. When you have feedback where you need amplification and multi-goal outcomes. Great example is blood clotting. When you're getting on a plane, you don't want to have a pulmonary embolus. So in general, you're not clotting. Now you accidentally cut yourself, you need to throw into action that clot. And of course, if you're a cave person, then you could die from cutting yourself if you don't clot. And that system has multi-goal outcomes, not clot, clot, back to the not clot. And it's got to amplify rapidly because otherwise you'll bleed to death. That has positive feedback. You have a system of serine proteases that actually feeds back on itself to make that clot. And the same sort of thing happens with making synapses. And this is where prions come into play. Prions are self-amplifying. So yes, if you get an injection of prions into your brain, you will make more prions. However, we believe that these actually are associated with biological positive feedback. This is prionic loop feedback. And this is what happens with APP itself. As you start going over to this protective mode and this pulling back mode, the amyloid actually feeds back to make it so that APP is cleaved in the amyloidogenic mode. Similarly, when you're going in the positive direction and you're now cleaving it into the two fragments that support the synaptoblastic fragments, they actually inhibit the amyloidogenic mode. So what happens there is you have a system that tends toward one of two stable states, growth and support versus now flipping over into protection and downsizing. It doesn't get stuck in the middle. It tends to go one way or the other. And so that is this prionic loop feedback. So the bottom line is, in the vast majority of cases, it doesn't look as if you catch dementia, but there is a phenomenon that accentuates it. And so in those cases, theoretically, you could catch it if you have this injected. But in general, we're not exposed to this process from other people. The catching it is really watching the other guys sit on the sofa all the time and eat horrible stuff and saying, yeah, I'm going to do that too. That's really the closest we get to catching it.
Can you come back from dementia? How rare is that for that to happen?
Yeah, so the idea of whether you come back from dementia is extremely controversial. And if you talk to the Alzheimer's Association, they'll tell you no. If you talk to a number of people at NIH, if you talk to a number of experts, they'll say no, despite the fact that we've repeatedly published multiple cases, and we published in 2018 100 documented cases. And so back in 2014, we published the first examples of reversal of cognitive decline. Now, again, think about the stages. It's easier earlier on, no question about it. But we've had people even in later stages who have improved and sustained their improvement. So the answer is, it's easy to come back from the earliest stage, subjective cognitive impairment. It's fairly easy to come back from the middle stage, mild cognitive impairment. And it sometimes happens, we've seen it, people coming back from Alzheimer's disease. That's where you're now moved over into dementia. And even we see people improve from late stage. Although the people in late stage, we can see improvement, they can dress themselves again, speak again. We haven't seen people come all the way back to complete normalcy. This is why we say, please get in early, because the outcome is much easier, much more assured, and much more positive. So it is my opinion, based on data we've published, that you can come back from dementia, which is not a guarantee that every single person will, but that it is, for the first time, possible based on our understanding of what's driving the process and targeting those things that are actually driving the process.
Has the medical industry supported your work? Why or why not?
Yeah, great point. There's been a tremendous amount of pushback because we're claiming something that hasn't been done before. I understand the skepticism. This has been the model for medicine for hundreds and hundreds of years. As you know, scurvy due to a vitamin C deficiency. The treatment for scurvy was rediscovered and skeptical, lost because of skepticism for hundreds and hundreds of years. Each century they would rediscover it. That we can do something about this. People say, no, that doesn't do it. So it takes a long time. And I go back often to Semmelweis, who was the guy in the early 1800s, who discovered that people were dying from so-called puerperal fever. From delivering your baby, you would get infected and die. And at the time, there wasn't an understanding of the germ theory of disease. So people said, well, there's no way that a little tiny bit of stuff under your fingernails could actually kill a whole human being. That just, it doesn't match here. And so they didn't understand the process. He discovered that you could wash your hands with sodium hypochlorite, good way to get things clean, and that he could bring down the risk of dying after childbirth to virtually zero. It was up at 15%. I mean, people were dying left and right. And there was such skepticism, despite the fact that he showed it very clearly with data, that he was ultimately confined to an insane asylum and ironically died from an infection within a couple of weeks. So very sad. So this is the history of medicine, that there's skepticism, and I get it. Of course, everybody wants to see more and more people in trials, of course. But the thing that is a little bit crazy is, makes sense when you've got something like you've got a fairly good treatment for cancer, but you want a better treatment. Okay, you want to wait until you have something that's clearly better. Right now, we have something that's clearly better than anything that's been used before. We're seeing repeatedly people get better. And so the idea of watching people die while we get 1,000 people together and do a $100 million trial is really ultimately abuse. And so we've originally reported 10. Yeah, it's a small number. It's anecdotal. We then reported another 10 where we had better documentation. We then reported 100 people. And now we've just finished a trial that shows very clearly that the majority of people can improve. If you do the right things, if you look for the right causes, if you identify them and you address them, the majority of people can turn around and actually get better. And I'm not surprised by the skepticism. That's fine. But as we get published these studies, more and more people will recognize that this is the approach. And by the way, of course, this isn't the final approach. We will, and people and we and others will enhance this and make this better and better and better. But the fundamental change here is not to predetermine a treatment for this illness, but rather to flip the script, to evaluate what's actually causing the problem and target those things. That is the basis of precision medicine that is working very well with cancers and is now working quite well with cognitive decline as well.
Does sunlight help prevent Alzheimer's?
To some extent, yes, in that it improves your vitamin D levels, and hypovitaminosis D, which so many of us suffer from, very, very common throughout the world, is one of the risk factors for Alzheimer's disease. And actually, vitamin D receptor SNPs are associated with Alzheimer's as well. So no question, vitamin D signaling, and this affects hundreds of genes, among those genes that are important for synaptogenesis and synaptic maintenance. So to some extent, yes, sunlight helpful, at least through the vitamin D. And of course, I think it's helpful just through impacting our depression and things like that as well. So yeah, for those reasons, yes.
Are there nutritional supplements that we should use or avoid to prevent Alzheimer's?
Right. The whole issue of nutritional supplementation, another very controversial area. And there's been a lot of criticism, and I think, fair criticism to some extent, because people say, hey, these people making supplements are making these ridiculous claims. You take my one supplement, you're going to be a genius. It's going to reverse your Alzheimer's. Of course, that's ridiculous. Again, we can see through the neurochemistry what it actually takes to change synaptic maintenance, to change synaptogenesis, and to change synaptic maintenance, to increase your synaptoblastic activity and decrease your synaptoclastic activity. Once you understand for each person what's driving that, Of course, there's a number of supplements, different for each person, that will be supportive. So some people, as you mentioned earlier, vitamin D, some people need to support their vitamin D, just as we do for better outcomes for COVID-19. Enhancing your ketosis. You can do that with some supplementation. Magnesium, another one, nice publications from Dr. Guosong Liu from MIT on magnesium threonate, using that to support your magnesium levels. Whole coffee fruit extract, good way to enhance your BDNF levels, which are also supportive. So again, there are dozens of things that are critical for optimal neurochemistry. And supplements, now please remember, they're called supplements because they're supplementary. There are other things we need to do as well. So this idea of take this one supplement and you're going to be a genius is ridiculous. But for targeted neurochemistry, absolutely. And anyone who's not taking advantage of the support that are given by supplements and by other things like brain training, each of these things by themselves, not particularly helpful, small amounts of help. But when you have the whole orchestrated and targeted protocol, you get much better results than people have seen before. So in that sense, yes, there are a number of these that can be very helpful. And curcumin, I mean, we could go on and on. There are all sorts of things that have, anti-inflammatory effects, SPMs that help resolve inflammation, so helpful. A number of things that can be helpful for insulin sensitivity. Creating insulin sensitivity is so important. When we would grow neurons in petri dishes to study them and to study their degeneration, we would always have to include insulin in there because insulin signaling is an important trophic impact on neurons. So if you've got insulin resistance, you are hurting yourself. And there are a number of things that can improve that. Even things like chromium picolinate and things like bergamot as another example. And there are many things, cinnamon even, things like this that can all be helpful for insulin sensitivity. So yes, absolutely. The right ones in the right way with the right manufacturer, so they're not giving you garbage, which is another thing that's unfortunately hurt the whole field. So we have to all do better to make sure that these things are top quality and that are approaching and directing themselves against the neurochemistry for each of us that is critical for best outcomes.
Are there any people that are at greater risk for Alzheimer's? What age, sex, race, and part of the world you live in puts you at a greater or lower risk?
Yeah, and again, you can go right back to this equation looking at the synaptoblastic and synaptoclastic signaling. So anything that affects those subtypes that we talked about, anything that gives you inflammation, anything that gives you glycotoxicity and insulin resistance, anything that is a reduction in support for the brain, anything that reduces the energetics for the brain, anything that is enhancing trauma, those things are all at risk. So as we age, because remember, it's integrating over time. You're looking at this. If you've got good synaptoblastic activity, great. When you drop below that, you're downsizing. So downsizing over years is what's giving you Alzheimer's disease. So ongoing systemic inflammation, absolutely. Greater age. Groups that unfortunately, just as we've seen with COVID-19, the whole health disparities, that is an issue. If you have poor vascular support, you have more vascular disease. So yes, it is true that your risk is increased in an African-American group versus a non-African-American group. There is an increased risk. There is an increased risk in a Latino group as well. Which is not to say that anyone has no risk, no question. And then of course, the genetic risk is a big one. And the most common genetic risk, and there are dozens of genes that increase risk, but the most common one is called ApoE4. And so your apolipoprotein E, most of us have either 2, 3, or 4. So for example, I checked myself, I'm a 3-3, which is the most common. That's like vanilla. If you have no copies of ApoE4, and that's about 3/4 of the population, your lifetime risk is about 9%. Not zero, but not terribly high. If you have a single copy, and that's 75 million Americans, then your risk during your lifetime about 30%. If you have 2 copies, and that's about 7 million Americans, your lifetime risk is well over 50%. Most likely you will develop Alzheimer's. And therefore, we'd like to get everybody to find out their status, get on prevention, and let's make it so that these people don't have to worry. And there's a wonderful website, apoe4.info. There are over 3,000 people, all ApoE4 positive, sharing information. The vast majority of them are on some variation of our protocol and doing very, very well. So there is a tremendous amount you can do. And absolutely, there's all sort of risk factors. I mentioned earlier, things like, and these things are, very different. They don't make sense unless you understand that signaling. So people with low vitamin D, people who have low testosterone, low estradiol, postmenopausal without BHRT, without hormone replacement, if you had an early oophorectomy. That's a nice study out of the Mayo Clinic. People with insulin resistance, with type 2 diabetes, people with obesity. All of these things, all these different risk factors, all feed into those same subtypes. People with any degree of vascular disease, so high triglyceride to HDL ratio, for example, high HSCRP, high homocysteine, poor detox apparatus. These things are all contributing to that same fundamental change.
And what impact does diet have on cognitive decline? How can diet reverse this?
Yeah, this is a great point. Diet is one of the most important risk factors. So most of us are on the standard American diet, as they say, SAD. And what does that do for us? It increases our blood pressure. It gives us insulin resistance. It gives us obesity. It gives us systemic inflammation, increased risk for heart disease, increased risk for metabolic syndrome and type 2 diabetes, and increased risk for dementia. So it's really a horrible thing for us in the long run. And optimizing our diet, on the other hand, with a mildly ketotic diet, plant rich, doesn't have to be all plants, have some, absolutely some wild caught fish, have some pastured chicken, have some grass-fed beef. All these things are wonderful. Or if you want to be a vegetarian, that's okay too. The whole point here is to drive your neurochemistry in a positive direction. Now, having said that, it's not a cure. Again, it's part of the overall orchestration, the coordination of what gives you best outcomes. But it is a very, very important component to get the best outcomes. And we recommend people, get high fiber, because that's helpful for detox. It's helpful for glycemic control. It's helpful for lipid control. And so it's helpful for your vascularization. It's amazing how helpful that is. And again, phytonutrient rich, plant rich, organic, especially because so many of these pesticides, major problem. So all of these things, folding them into an optimal diet can be very, very helpful.
In your book, The End of Alzheimer's, there's a chapter called Disrupting Dementia. Please explain what this was about.
Right. So the whole idea of disrupting dementia is just that we've had this static view of dementia for years. And it's interesting. Every expert learned that line, and they would say this at every meeting. They would say, there is nothing that will prevent, reverse, or delay Alzheimer's disease. And that was just this mantra that everyone would spew. And that made you feel very scientific. I know this. This is very scientific. Well, in fact, that's wrong. And so what we're saying is we are disrupting with the science, looking for all those years, and this is literally coming directly from the test tube, looking at what drives the problem. That's no longer the case. So we are disrupting the idea of dementia and what can be done about it.
How does exercise impact dementia?
Great point. And as many groups have pointed out, exercise is a major player. It's actually very helpful, but on both sides. Sedentary lifestyle, very supportive of Alzheimer's, and exercise, especially optimal exercise, very good against Alzheimer's. And again, start early, very powerful effects. And it's multiple ways. Again, let's go back to the biochemistry. What does it actually do? Well, number one, it improves your insulin sensitivity. So you are, for one thing, weight training actually helps. Your muscles have insulin receptors on them. You are improving your insulin sensitivity. You are also improving your oxygenation. You are also improving your cerebral blood flow. You are also enhancing your ketosis. Interestingly, ketones actually enter your brain, interact with specific ketones, or specific histones, sorry, the histones which actually are preventing the production of BDNF. These are then removing that inhibition and showing that there's now an increase in your BDNF. This has been noted repeatedly, the increase in BDNF with exercise. It also, of course, improves blood pressure in the long run, improves your quality of sleep in the long run, reduces your likelihood of depression in the long run. So there are many, many ways, and we recommend both aerobic and strength training because they have complementary positive effects for cognition and for prevention of cognitive decline, as well as helping with the overall reversal of cognitive decline.
Does too much or too little dietary fat contribute to dementia?
Yeah, so this is another good point. And again, it's not so simple to say it's good or bad. We've all heard about, being the amyloid was vilified, and then of course fat was vilified. Well, the wrong kind of fat in the wrong way can be a problem. If you've got inflammatory fat, if you've got a lot of saturated fat, and there's something we call the Bermuda triangle. You have three things. This was first pointed out by Dr. Mark Hyman years ago, and it's a very good point that he made, which is that if you've got the combination of saturated fat, and you've got high simple carbs, so you're now eating sugar. This is, basically go out and get a cheeseburger, fries, and a Coke or a soft drink, and you've got very low fiber. So you're now also not getting rid of that high carb intake. That is a horrible triad and really increases your risk for a number of diseases, including cognitive decline. So that's the way you don't want to have fat. On the other hand, if you look at what are the diets that are actually associated with best cognitive outcomes, they are high fat and polyunsaturated fats, monounsaturates, excellent, but small amount of saturated fat is fine as long as you've got also you're getting the fiber, and you check your LDL particle number, make sure that you've got a good profile. So it's high fat, intermediate protein, low carb, and virtually no simple carbs. These things are very damaging. And so that's where, fats, that is a very positive thing in terms of a combustible substrate. You're helping to produce these ketone bodies. So this is a mildly ketotic diet. We like to see people between 1.0 and 4.0 millimolar beta hydroxybutyrate. And if you don't want to measure it in your blood, you want to measure it with a breathalyzer, great. There's something called a BioSense that is a very nice, simple thing to use. And you'd like to get above 7 and at least at one time of the day above 10 on these so-called ACEs. And that's very similar to getting 1 to 4 in the BHB, in the beta hydroxybutyrate that you get from a finger stick. So please get yourself into mild ketosis as part of the overall plan. It gives best outcomes. It allows you to bridge that energy gap.
Others have said Alzheimer's is type 3 diabetes. Do you agree with this?
Not completely. So the idea here is correct. That is, type 3 diabetes, yes, no question, insulin resistance, very important. Type 2 diabetes increases your risk. But as you can tell from this neurochemical imbalance, you can get there without diabetes. Yes, it's a common contributor. And so in that sense, yes, type 2 diabetes and insulin resistance are clear contributors, but they're not the only ones. You can also get there through toxicity. You can also get there through inflammation. They're just some of the most common ones.
So what happens to synapses when you develop insulin resistance? How does this impact the proliferation of Alzheimer's?
Yeah, good point. So what happens is insulin binds to the insulin receptor, And the major molecule downstream from that is called IRS1. And IRS1 gets phosphorylated. When you're signaling positively through the insulin receptor, the IRS1 gets tyrosine phosphorylation, and there's low serine and threonine phosphorylation. So that's on. That's signaling positive. That's signaling survival. That's signaling metabolism, that to deal with the glucose that's being metabolized. On the other hand, when you have this chronic increase, you've had a high carb diet, you've got this insulin that's up there for so long, then in fact you develop insulin resistance. Now what happens is the tyrosine phosphorylation is going down, and now the serine and threonine phosphorylation, especially at specific residues, goes up. And so this is a little bit like, imagine that every day you come home and your son is playing the drums really loud. So you're putting on earplugs, right? You don't want to hear this. And now what happens is your wife come home, you've got the earplugs on, and she puts on a Brahms lullaby. You can't hear it. So this is exactly what's happening with insulin resistance. As you now start to lose the ability to make enough insulin because you're way high for years, then in fact, now you're unable to signal. You're not getting that trophic support that you should be getting from this. And therefore, we like to look at the HOMA-IR, which is telling you how much insulin resistance you actually have. And we want to get their HOMA-IRs to be optimized down around 1.0. We see people all the time coming in with HOMA-IRs of 3, 4, 5, even higher. And these are telling you have a lot of insulin resistance. You are increasing your risk for cognitive decline.
What types of mental activities should we be doing to help prevent dementia? Should we do puzzles or read a lot?
Yeah, it's a good point. You don't want to go to the point of giving yourself a lot of stress, because stress actually is another thing that causes this downsize, unfortunately. And so this is good. And I should mention before we move on, also, poor sleep. One of the things we haven't talked about, it's a huge issue. Poor oxygenation during sleep, huge issue. And of course, stress can make people wake up in the middle of the night, huge problem. So what we want to do then is to get people to have optimal outcomes where we minimize their stress and we improve their overall signaling. So this is a critical issue. So as I said, you want to make sure that you don't have super amount of stress, but the actual brain training itself is helpful. And again, this has been controversial because people have said, well, what if you just do this one thing? This idea that any one thing is the optimal is kind of silly and reductionist, not helping. We want to be able to look at an optimal overall approach, and brain training is helpful. Now, people have talked about, should this be puzzles? Should this be learning a new language, learning a new instrument? Any of these things can be helpful. However, let's look at where the data are. There are published data, mostly from one type, which was set up by Professor Mike Merznick years ago, and this is called Brain HQ. So these other things can be helpful. We just don't have as much data yet. We recommend that people try Brain HQ simply because we know that the data support a reduced risk for cognitive decline and an enhanced improvement when you use that approach. And so you are driving your brain, but again, you don't want to do it so much. And so we recommend if it's very fatiguing and stressing, start with a small amount. Start with 5 minutes a couple times a week. Work yourself up to the point that you can do 30 minutes 3 times a week, or even 15 minutes 4 or 5 times a week. That will help. And think about things that enhance your speed. There's one that they have called Hawkeye, another one's called Double Decision. They've published some nice work on Double Decision. So these are the sorts of things that are helpful. But yes, absolutely, if you like Sudoku, if you like learning new languages, these things can all potentially be beneficial. We just have fewer data points on these.
Are certain minerals a cause of Alzheimer's, such as copper? Should we avoid certain nutritional supplements because they have minerals in them?
Yeah, this is a very good point. That again, all things we have to get the optimal, and so most things in biology, too little not good, too much not good either. The bad actors in Alzheimer's, mercury is the big one that we really have to be careful about. It is the most common one that high levels of mercury do literally give you the pathology of Alzheimer's disease. Others can contribute because they are making it, they're damaging your detox and they're making it more that you've just got the total amount of toxic burden is an issue for people. So they can enhance the problem that you have from these other toxins. And yes, copper is a big one. High copper to zinc ratio, often associated with overall toxic burden. And it's been pointed out that we tend to have exposure to too much copper and too little zinc. There are about 1 billion people on the globe who are zinc deficient. It's one of the most common deficiencies, unfortunately, and that is associated with cognitive decline. So these are all important. Magnesium, another common one, and both zinc and magnesium critical, by the way, for insulin function and for keeping us out of type 2 diabetes. So these things, again, all work together. And yes, these can absolutely be, and then these can absolutely be increasing your risk. And so also lead and other metals, arsenic, very, very common, and they can contribute, although again, they're not as commonly the dominant one as mercury is.
What molds are the main ones that are linked to Alzheimer's?
It's a good point that if you look at all the different toxic cases of Alzheimer's, the biotoxins seem to be the most common. Again, that's not to downplay things like mercury, where there are very clear evidence. And this another area that has not been accepted by the general medical community, and yet we're seeing it again and again and again. And we see that when people have mycotoxicity associated with cognitive decline, they don't get better until you reduce those mycotoxins. And first published this back in 2016. It's been very clear, thousands of cases. And it's been known for years that people who have mycotoxicity can often have some brain fog. It wasn't clear that they actually developing Alzheimer's. But again, think about it. Alzheimer's, you're dealing with insults. You're making this amyloid that is actually an antimicrobial, and it does have an antifungal effect, among other effects. And so therefore, it's not surprising that people who have these mycotoxins would ultimately develop Alzheimer's disease. Again, continued exposure to these is a big problem. We want to identify these. We want to remove that exposure as part of getting an optimal outcome. And these come in numerous different types. So there's trichothecenes, ochratoxin A, gliotoxin, things like this. And these not only damage your neural system, but they also damage other systems. And one of the big ones is they have immunotoxicity. So these molds are normally going to be dealt with by your adaptive immune system. So of course, they want to reduce, and they produce factors that reduce your ability to get rid of them so that they can actually live with you and in you, and they can be there in your sinuses chronically, as people know. They can be in your gut, for example, and so numerous. And of course, they can live in your brain as well. And if you look, and pathologists have done a nice job looking at the brains of patients with Alzheimer's, and what do you find? You find bacteria. You find things like P. gingivalis. You find viruses like HSV1 or HHV6A. You find molds. You find even yeast like Candida and things like that. So you find these different organisms in the brains of patients with Alzheimer's disease. So no surprise that these toxins are things that are associated with cognitive decline and that we need to treat.
What does outdoor exposure have to do with dementia?
Well, in general, we'd like to see people outdoors more, because indoor, you're going to have more exposure to things like mycotoxins. Unfortunately, most of us build our homes out of mold food. And so we end up, especially if you have any sort of water damage, that's a problem. But when you go outdoors, be careful. You want it there. With the problem, of course, is air pollution. And of course, here in California, we have the California fires. We've had them now a couple of years. And these things are going to increase risk for dementia. If you look at the people who were exposed to the World Trade Center cloud as an example of poor air quality, 13% of those people had already, by 2016, developed cognitive decline, and many of these relatively young people. So this is a huge issue, and more data now showing that air pollution is associated with cognitive decline. So that's the main thing. We want to be exposed to clean air. We want to be exposed, stay away from both the mycotoxins of the indoors and the air pollution of the outdoors. It really turns out to be critical for risk. And it's been shown that people who have ApoE4, who have increased risk because of their pro-inflammatory state, also have increased risk if they are associated, if they have exposure to air pollution.
What more can you tell us about the process of how neurodegeneration actually occurs? What are the molecular events that drive the process of that neurodegeneration?
Yeah, so there's a whole set of events. This is, humans are complicated organisms. And at the center, as I mentioned earlier, this amyloid precursor protein that can be, that can produce 2 synaptoblastic peptides or 4 synaptoclastic peptides. Now, it also signals downstream to lead to phosphorylation of tau. And tau is an interesting molecule that is phosphorylated in association with Alzheimer's disease. And again, been vilified. People say, oh, that's the tau, that's the problem. Well, it's responding to the overall signaling again. And some of that tau phosphorylation is coming from APP itself, others from other sources, but it is part of the downsizing. And so tau is a stabilizer, which actually stabilizes microtubules. So when you're now growing these things out and you're having your axons connect, you need that stabilization. If you're going to pull that back rapidly when you signal, oh, synaptoclastic activity, then what happens is you phosphorylate the tau, which is what pops it off. You can think of this a little bit like bolts. This pops off the bolts and allows this to collapse. So no surprise, when there's lots of collapse going on, you now look and you say, oh, there's tau phosphorylation. It also it signals in multiple other ways. Interestingly, both tau and ApoE enter the nucleus and actually affect gene transcription. So again, you're changing the program. You're going from a production mode to a destruction, to a pullback and protection mode, from a growth mode to a protection mode. And that involves changes in tau, changes in signaling, changes in APP cleavage, and all sorts of downstream signaling related to a number of molecules. GSK3 beta is one of the things that actually phosphorylates the tau. And interestingly, that one's inhibited by lithium. Now, again, too much lithium, very bad, very toxic, but many people will take small amounts of lithium as part of an overall optimal program, 5 or 10 milligrams as an example. And so there are all sorts of signaling mechanisms that are critical. If you look at APP itself, it interacts with a molecule called P75, which is something that binds to nerve growth factor. It's part of the overall nerve growth factor receptor complex, which is TrkA and P75. This interacts with dozens of other molecules. So again, it comes back to the fact that this is a master regulator. This is like the president of your country saying, things are good. We're going to forge new alliances. We're going to build new bridges. We're going to grow our country, versus your president saying, oh my gosh, we're being attacked. We're going to have to now put some napalm on these attackers. That's the amyloid. This is the antimicrobial effect. And we're going to have to now live in a slightly smaller country. We're going to pull back as we are protecting ourselves.
Please explain what your program is to prevent and reverse cognitive decline.
Right. So the fundamental difference between what everything that we've done and what's been done previously is that, as I said earlier, we're not predetermining a treatment and saying, okay, you got Alzheimer's, we don't know what causes it, we're going to give you a drug, it's not going to work, you're going to die. I mean, that's the old-fashioned approach. We're saying, no, we need to understand for each person, and preferably as early as possible, what's causing the decline. We look at dozens and dozens. Right now, we evaluate 150 different factors, and they include historical factors, things like, and they include genetic factors, and things historically, have you had depression? Have you, which suggests that you may have some inflammatory characteristics. Do you have mercury in your mouth? Do you have gut symptoms? I mean, these are all part of the story. So we want to look at the human organism as the complicated, the coordinated functional unit that it is. And then we evaluate appropriate lab data. And from that, we construct an overall look. We have a computer-based algorithm that we have produced, which now subtypes people and says, okay, you have mostly an inflammatory type, or you have mostly an atrophic type, or a glycotoxic type, or a toxic type. And then from that, we can derive an optimal program. And of course, it includes optimal nutrition. The idea of ignoring all these things and just giving someone one little drug that does one little thing is really a naive approach to the overall problem. You're dealing with a complex system. And so we want to attack this with the appropriate drivers. And yes, it typically includes some supplementation. It may include specific drugs, and we would argue that drugs are going to work much better when you are doing the right things. And therefore, we believe that in the future, drug trials should be done on the backbone of an optimal approach. This idea of where things are bad and you have essentially a floor effect. You don't see anything with a single drug. Let's get people up into a dynamic range, and now we can see small impacts. And by the way, we hear this all the time. Someone says, oh yeah, I can see that adding or subtracting something, I can see it getting a little better or a little worse, because they're now in a dynamic range as opposed to being in a place where things are so bad. There are so many problems that no single thing you do has a real impact. So that's the idea, that this is a precision medicine personalized protocol that identifies and addresses the drivers of the cognitive decline.
When dealing with Alzheimer's disease, why is it important to identify that root cause?
Because if you are not addressing the root cause contributors, of which again, 10, 25, there's a number of these, then you're circumventing those. So even though you may get a little improvement, the underlying problem has not been quelled, and therefore it is continuing. You're going to have problems in the future. So even at the best, you get a short-term solution, which again, we haven't seen with the drugs, even a short-term solution. You're going to go right back to degenerating because you haven't gotten rid of what's actually causing the problem, which is why it's so critical to do that. Now, if you get rid of what's causing the problem, at the very least, you're going to be more stable. Now, if you're now improving things and getting appropriate synaptoblastic activity and appropriate support, you're now actually going to see improvement, which is what we see repeatedly.
You mentioned the importance of sleep in preventing dementia. Is there a correct way to sleep? Should we be asleep by 10? How do we get enough oxygen while we're sleeping? How do you increase the oxygen saturation when you're sleeping?
Yeah, it's a great point. And there's a wonderful book on sleep and all the aspects of sleep by an expert in this, Professor Matthew Walker, called Why We Sleep. The biggest problem we see repeatedly is nocturnal hypoxia. And in fact, there's a nice paper showing literally as your oxygen goes down at night, you can show a direct correlation with the size of specific nuclei within the brain. So as your oxygenation is going down at night, your brain size is going down. We want to keep that oxygenation up 96 to 98%. For some people, that just means sleeping on your side. The main thing is find out what it is. For some people, that will mean CPAP. For some people, a simple dental device. Whatever it takes, you want to make sure that you have appropriate oxygenation while you're sleeping at night. But then there are all sorts of other issues. People waking up in the middle of the night, unable to go back to sleep. Some of those people, it's because they've gotten hypoglycemic and they don't know it. If you have a diet that is a relatively high carb diet, then what'll happen is you often will spike your insulin. So you see these increases, then you'll see these troughs, and people will wake up in the middle of the night not realizing it's because their glucose is 45 or 50 and it's plummeted, which is also harmful. So I think one of the biggest advances has been these CGMs, continuous glucose monitoring. Very nice. And I recommend everyone, please check your oxygenation overnight. Easy to do. You can do it with an oximeter. You can do it with an Apple Watch. You can do it with something called Bedder. There are all sorts of ways, excuse me, to do this. And you can check it with your doctor. Have your doctor loan you an oximeter. You can have them send you for a sleep study. Lots of ways to do that. Also, though, check your glucose. What you'll find is there are certain foods you may not have recognized that are spiking your insulin and your glucose. And then there are others where you're now plummeting at night. You need to smooth this out, and that you do that with a high good fats, intermediate protein, low carb diet. Some people will even take shots of extra virgin olive oil. Get that fat so that you now are stabilizing your glycemic load, stabilizing your glucose while you're sleeping. And then there's all sorts of sleep hygiene, turning down appropriate things early. Get some blue blockers. Don't be exposed to things that are keeping you going. Don't watch a scary horror movie right before you go to bed. There are all sorts of things. And again, we went through all of these in the book, The End of Alzheimer's Program, that just came out in August of 2020, and actually worked with someone who's doing this herself each day and doing very, very well. And this is Julie Gregory, the one who founded apoe4.info. So all these things, very helpful. Optimal sleep has been shown repeatedly to improve cognition and to reduce the risk for cognitive decline.
In your book, The End of Alzheimer's, there was a chapter called Success and the Social Network, Two People's Daily Routines.
Right.
Please explain what this was about.
Right. So my point there was that one of the most powerful things that's going to change our global burden of dementia is the social network. People are talking to each other now. I wrote this because I went to a meeting where a number of people from apoe4.info came to the meeting. They talked about going on our program and how they had improved things and what they were doing to optimize. And they shared secrets. Hey, I didn't like this one, but this one was working better. By the way, I tried this form of curcumin, didn't work for me, but this form of curcumin did. The ability to share information globally and immediately is going to have a profound, and I think already is having a profound impact on our global health and our global burden of cognitive decline. So in that chapter, I also went through, here are two people and what they've done. One who was doing many, many things and doing very well. Another who wasn't doing so many, but was doing enough to get over the hump. There is a threshold, just as Dr. Dean Ornish showed years ago for cardiovascular disease. You have to get over a threshold. Again, synaptoclastic activity. Until you get to that appropriate point, you're not going to get a good outcome. But once you pass that, you're now seeing improved outcomes. So that was the idea for that chapter.
Does stress, worry, constant daydreaming tax your brain and lead to dementia?
Absolutely. And you can just take people and look at people who are under chronic stress and have high cortisol levels. Their brains are shrunk. So we want to improve that. And by the way, we do see people increase their brain volumes when they do the right things. So you do have plasticity there. There's no question about it. And so absolutely. And in fact, we have developed drugs over the years looking in the laboratory. And one of the things is that if you bind to a stress-related receptor called CRF receptor 1, in fact, you have a positive impact. If you prevent that signal, you have a positive impact on both A beta and tau. So in fact, yeah, absolutely stress. And the whole it's not just insults, it's perception of insults. They actually both give this pro-Alzheimer effect on your brain. We're measuring these various insults like the various pathogens and inflammation, but threat is also something that is a pro-Alzheimer's effect. So stress. Now, short periods of stress with resolution actually supportive. This is a hormetic effect. It's the chronic, unmitigated stress that is really damaging.
Are there any studies showing that anesthesia or being put to sleep for a medical operation has an impact on dementia.
Yes, many studies showing that anesthesia use is associated with subsequent cognitive decline, unfortunately. And so, again, we have a piece in the book that goes through if you're going to have to go undergo general anesthesia, please, here are several things that you can do to mitigate the problem. Because we hear this story all the time. You know, so-and-so was doing well, and then they had anesthesia, and then over the next several months, they started to show some cognitive decline. You have multiple impacts from this. It is a toxin, so you've got to clear that toxin, therefore reduces your ability to clear other toxins that are already on board. Many people also have some hypoxia during their anesthesia. So yeah, for the multiple negative impacts of this. So if you can do it with local, that's great. If you can't, you have to undergo general. It happens. Make sure that you get ready for it, and then you can also do several things afterwards as well to give yourself better outcomes and lower your risk.
You mentioned getting a cognitivoscopy earlier. Can you tell us more about what it is? Where do you get it? What does it do for you if you're having cognitive decline?
Yeah, and this is, cognoscopy, easy to do. It's 3 pieces, and you can actually go on mycognoscopy.com and you can get this directly. It's a set of blood tests that will look at what are your risk factors. It's a simple online cognitive assessment. So you're looking at, hey, again, maybe things are a little worse than I thought they were. Again, this sneaks up on so many people, and they're surprised to find, wow, my cognition is not as good as I thought it was. I really better get on treatment now. And then the third part, which is an MRI with volumetrics. Like if you don't have any symptoms, you don't need to do the third part. If you do have symptoms, good idea to get an MRI with volumetrics. But whether or not you do that third part, please make sure to get the appropriate testing and the appropriate online cognitive assessment to see where you stand and to get on optimal either prevention or reversal as early as possible.
Does meditation impact dementia?
Yeah, as a scientist, I really thought these things were silly years ago. I thought, stuff like joy and meditation. This is all about molecules. It's all about science. But, I have to say, I cannot deny the published data. Meditation clearly helps with neuroplasticity. It clearly helps with blood pressure, clearly helps with depression, a number of things, which is why people have done it over thousands of years. Whether you like, transcendental meditation or you like mindfulness or what have you. There's Kirtan Kriya that has been pointed out. There's a lot of studies showing its improvement with cognition and improvement and reduction of risk for dementia. So, or you like something else, these are all helpful. And this, of course, gets into yoga as well. These, again, all part of improving outcomes and improving neuroplasticity. Meditation turns out to be something that, as part of an overall program, can be quite helpful.
What studies have you done or read that has made you believe that Alzheimer's can be prevented, slowed, or stopped?
Yeah, because we've seen it. And I just got another email from one of the practitioners yesterday. We've now trained 1,750 practitioners from 10 different countries and all over the US. I hear from them, various ones all the time, that they're seeing repeatedly people getting better and staying better. So I've seen it with my own eyes, and we've published it repeatedly. So I think there's little doubt at this point. Now, what we really, again, instead of arguing about can they, we really want to be saying, okay, how can we do better? What about the ones who are far advanced and aren't doing well? What can we add to make that better? Can we guarantee people that they will be better? What are the things that we can do? What about the non-Alzheimer's? What about frontotemporal dementia? And what about Lewy body? We've had good results with Lewy body disease. So far, a lot that we don't know about frontotemporal dementia, which is much less common, but is an important cause of dementia. So there's no question that you can see reversal of cognitive decline. We've seen it, we've documented it, we've published it repeatedly.
Can stem cells help someone who already has Alzheimer's?
Yeah, that's a good point. I think in the long run, stem cells will be important because when you think about it, you're doing 3 things. You're removing the causes of the decline. You're now improving resilience. You're optimizing all these factors, the hormones, the trophic factors, et cetera. But then you also want to rebuild what's been lost. And stem cells can be very powerful in the rebuilding part. They also can be powerful in supporting your immune function. Immune abnormalities, the critical role in COVID-19, critical role in Alzheimer's disease. We hear about cytokine storm which is in COVID, where you've got this in the inflammatory part without enough adaptive part. Same thing happens in Alzheimer's, but in this case, it's over years. So it's really more of a cytokine dribble than it is a cytokine storm, but it contributes to it. But stem cells enhance your immune support, enhance your trophic support. Now, there are ongoing trials where they're using these as a monotherapy. My argument there is that it's a little bit like trying to rebuild a house as it's burning down. It really doesn't make a lot of scientific sense. So what you want to do is put out the fire first, do all the right things, and then add the stem cells. And I think that there's going to be a big role for stem cells going forward.
You've said over 400 Alzheimer's drugs have failed.
Yes.
How many have succeeded?
So mainly two. So and when when we say succeeded, they have a tiny, very tiny effect. And so the two that have succeeded, Aricept and Namenda, and those are typically used. And then there are a few others that mimic Aricept. But these are very modest effects. And in fact, a statistician told me that you could literally have said memantine either worked or didn't work. It was right on the border. And I should point out a couple of the antibodies, and in general, the antibodies have all failed, but a couple have been touted recently as being big successes. These did not improve anybody with Alzheimer's. They didn't stop the decline. They slowed the decline by about a third. So if you want to call that success, okay. But it's not what we're looking for. We're looking for actually improving people, and that's what the overall protocol does. Again, I think there's going to be a role for these antibodies in that after you've done everything else and improved someone, you want to get rid of the existing amyloid that's been around for years. And I think these things can be helpful. If you get rid of that and do nothing else, you're simply removing an antimicrobial protectant.
Should we take far-red infrared saunas to remove toxins from our body?
As again, so many of us are exposed to toxins like never before. They're in the air we breathe, they're in the water we drink, they're in our homes, they're everywhere. And so most of us have a very significant toxic burden. And those of us who don't have good detoxification apparatus that may have nulls in some of their glutathione related genes are going to be at increased risk over the others. And they're going to end up not realizing at the point until they get a cancer or they get cognitive decline or other problems. And so absolutely detoxification. We have a whole section in the book about detoxification. We also have it in the guides that we use for people who are on the program. This is important. And part of that is sweating, and part of that, sauna is a good way to go, exercise. And then you want to, as you're sweating out some of these toxins, which does occur, you can eliminate them through your colon. You're eliminating them through your urine. You're eliminating them through sweating. All of these things are useful, and you want to obviously reduce your intake of these various toxins as well, because again, it's a dynamic balance. If you're putting in a lot of them and you're not getting rid of a lot of them, you're in trouble. You want to put in fewer and get rid of more, and now you're in good shape. And so as part of that, a sauna can be very helpful, and you want to follow up the sweating with a non-toxic soap like a Castile soap or one of those.
Does too much screen time increase dementia?
Yeah, indirectly it can. There doesn't seem to be a direct cause. But yes, again, as part of an overall, it reduces your quality of sleep. So this is why, at night when you're going to use this, use either blue blockers or use an appropriate program so that you don't have so much blue light. This can be damaging not only to your sleep, also damaging, by the way, to your retina, increases your risk for macular degeneration, which has its own separate balance there. And one that we're now attacking as well, looking at changing that balance, a separate biochemistry, but the same general idea. And so, yes, too much screen time. It also is associated with sedentary lifestyle. It also is associated with increased stress. So, appropriate time, be careful. Of course, we all spend the days on our computers and doing, and especially with the Zoom meetings that we're all doing with the pandemic. It's important. It's an important thing, but also important, get up. This is why everyone reminds you, get up and move around at least once every hour. Don't be sitting there for too long. Sitting is, as they say, sitting's the new smoking. So for all those reasons, yes, be careful about the overall amount of time, and just remember that you want to have exercise as well.
Does use of cell phones and the wireless radiation from them have any impact on dementia?
Yeah, this is still a controversial area, and the answer is not in. The jury's still out on this. We don't know. There are some people that are absolutely convinced that things like Wi-Fi and cell phone exposure are damaging. And I think in the long run, when we have a better way to measure, this is the problem right now. We don't have a simple clinical lab test to say, aha, it's your cell phone that gave you this cognitive decline. But I won't be that surprised if it's one of the many contributors. Again, we're all exposed to chemotoxins, biotoxins, and these physical toxins, EMFs and things like that, like never before. So what we really need right now is a simple lab test to show that, yes, that's one of the causes of your cognitive decline.
So as we bring this to a close, why was it important for you to come speak here at the Real Truth About Health conference?
Yeah, as someone who spent my career in academics, to see that what we are doing in the clinic does not reflect what the basic science is telling us. This is, of course, what we went through with COVID-19. People did all sorts of crazy things at times, and ultimately we started realizing, okay, there's certain things that we need to do, and it does impact what you are doing, how you are living, what you're eating, what your vitamin D and zinc and all these things. I realized that there is a huge gap between what we see in the test tube and what we can actually see with this theory and with how this disease actually works and the way people are going about it. And I realized there are millions and millions of needless deaths. Unfortunately, this should be a rare disease. And as we talked about earlier, this should be a past scourge instead of being the current pandemic it is. Alzheimer's will take the lives of about 45 million of the currently living Americans. We can do much, much better, and we should do much, much better, which is why I want to get the word out. So I think it's important for everyone to understand this, that for the first time, Alzheimer's is an option. You don't have to get it. Start early, do the right things. You can really give yourself a very, very low risk. You can reduce your risk to almost zero if you do the right things.
Well, we thank you for joining us and again, for all of your meaningful work, and sharing it with our audience. Very, very important.
Absolutely.
With that, thank you so much. We'll see you at the conference.
All right. Great to talk to you. Thanks very much.
Take care. Be well.
Stay safe. Okay. Bye-bye.